Good morning, guys. Today we will talk about superficial thrombophlebitis. Introduction. Superficial thrombophlebitis is an inflammatory disorder of superficial veins with coexistent venous thrombosis. On the right side, you see the picture of the thrombophlebitis and how it looks like. If you remember, lymphangitis and inflammation of lymphatic vessel looks this one, but etiology, swelling, some not. It usually affects lower limbs, particularly the great saphenous vein or the small short saphenous vein. However, it can occur at other sites and may occur bilaterally. Traditionally, this relatively common process was considered benign itself. There in the picture you see the creative peroneal, posterior tibial vein, the common femoral vein, the femoral oblique vein, and well, yeah. And there you see the common internal. Now, what this picture showing you that we have a superficial and deep vein thrombosis. The deep vein thrombosis we will check, or I will explain it for you in the next lecture. More recently, superficial phlebitis, also called superficial venous thrombosis (SVT), has been associated with other venous thromboembolic disorders, primarily deep venous thrombosis and pulmonary embolism. Here in the right side you see the deep vein thrombosis. See how it looks like, just a big swelling on the leg. And pulmonary embolism, when we have the embol inside the pulmonary arteries. Therefore, it involves more than a purely clinical diagnosis with supportive treatment. Affected patients have an increased risk for recurrence of venous thromboembolic events. Herein, the terms of superficial thrombophlebitis and superficial vein thrombosis will be used interchangeably. It is the same. In Russia, we use thrombophlebitis like a calling of this disease. Etiology. Hypercoagulable state, prolonged immobilization, or vessel wall trauma may increase the risk of SVT. Superficial thrombophlebitis accounts for 5.4% of the adjusted population attributable risk for initial DVT or PE. SVT has been the presenting symptom in certain inheritable thrombophilias. According to several studies, it occurs in 11 to 15% of patients with protein C or S deficiency and approximately 40% of patients with factor V Leiden mutation. However, another study showed that these results were not statistically significant. In pregnancy, the risk of SVT is akin to that of DVT, most commonly in the postpartum period. Advanced stage exogenous estrogens, autoimmune or infectious disease, obesity, recent trauma or surgery, active malignancy, history of venous thromboembolic disease, and respiratory or cardiac failure also increase the risk of SVT. Prior occurrences increase the risk of subsequent ones. As noted, in 75% to 88% of cases, varicose veins are considered the most important clinically identifiable predisposing factor for SVT. In the picture you see the stages of varicose veins. First of all, we see reticular veins or spider veins. The second stage, we see the varicose veins or venous nodes. Again, there. In the third one, edema of the lower legs. You see the small swelling of this. And the fourth one, it is varicose eczema. Here you see the skin and trophic ulcers. Because in the last one, edema will decrease blood flow in artery and it lead to problem with trophic of the skin. The true incidence of superficial thrombophlebitis is unclear. In France, one community-based study notes the incidence of SVT to be 0.64%, while a different community-based study found the incidence to be half that of DVT and similar to pulmonary embolism. Other studies suggest its prevalence in the general population is 2 to 6 times higher than the incidence of DVT and PE. SVT is commonly seen in the outpatient population, usually women who made up 50% to 70% of the affected patients in one study. 60 years mean age, a body mass index that exceeds 25 kg per meter, and in those with varicose veins. For people who have a history of SVT, the lifetime risk of DVT or PE increases 4 to 6 times. And in Russia, we call this disease chronic venous thromboembolic Evans disease. No, excuse me. Post-thromboembolic Evans disease. Post-thromboembolic disease. Post-thromboembolic Evans disease. No, you can mix how you want. The reason don't change. While the 3 months mortality is about 5% in patients with DVT or pulmonary embolism, it is less than 1% for those with thrombophlebitis. One suggested reason for the lower mortality in patients with SVT is the younger age of the patients with fever-associated comorbidities. The migration of the thrombus towards the deep veins at the saphenofemoral junction, the saphenopapillary junction, or from a perforating vein during a state of hypercoagulability may cause the association between SVT and DVT or PE. Superficial thrombophlebitis starts with microscopic thrombosis when there is venous turbulence or stasis vessel wall injuries. Abnormal coagulability or vessel wall injuries, microthrombi could propagate and subsequently from macroscopic thrombi. Vascular endothelial injury reliably results in thrombus formation by triggering an inflammatory response that results in immediate platelet adhesion. Platelet aggregation is mediated by thrombin and thromboxane A2. Patients with superficial thrombophlebitis typically present with a reddened, warm, inflamed tender area overlying the track of a superficial vein. There is often a palpable cord. Some surrounding edema or associated pruritus may occur. Significant swelling of the limb is more commonly associated with DVT and should only be attributed to SVT after DVT has been excluded. Patients may have a history of antecedent trauma, which can include intravenous cannulation or infusion of irritants, such as recent sclerotherapy for varicose veins. A careful history is critical to identify risk factors for venous thromboembolism. Initial presentation in patients older than 40 years without other risk factors should prompt consideration of underlying malignancy. Patients with migratory thrombophlebitis, a well-documented paraneoplastic phenomenon, should also be further evaluated for underlying malignancy. Migratory thrombophlebitis is usually associated with pancreatic or other visceral malignancies and is often referred to as Trousseau syndrome. It can be present in complaint in 5% to 15% of pancreatic cancer, particularly of the body and tail. And in the right side you see the Dr. Trousseau. Traditionally, superficial thrombophlebitis was a clinical diagnosis. However, with the increased realization of stations with concomitant DVT or PE, compressive ultrasonography is recommended. Physical examination does not adequately identify the extent of disease. It has been shown to underestimate it in up to 77% of instances. Compressive ultrasonography can identify concomitant DVT, evaluate the extent of the thrombus, and confirm the diagnosis. The prospective observational superficial thrombophlebitis study reviewed venous duplex screening of the affected lower limb and showed that 23.5% of patients had concurrent DVT. More than half of these DVTs were not contiguous with the SVT. 17% were noted to affect the contralateral lower extremity, while only 1% had an isolated DVT in the contralateral limb. These findings support the regular use of ultrasound to evaluate SVT. The post yeah, prospective observational superficial thrombophlebitis study also sought to establish the ultrasonic findings that increase the likelihood of associated DVT. It found that the risks substantially increased if a perforation vein was involved with an odds ratio of 8.1 or if there was an SVT present less than 3 cm from the saphenofemoral junction, which had an odds ratio of 3.3. D-dimer testing is of limited utility in detection SVT. It is variable elevated in SVT and cannot be used to distinguish isolated SVT from DVT. Experts debate whether patients who present with extensive superficial thrombophlebitis without an apparent inciting reason should have an evaluation for thrombophilia, given the hypercoagulability is associated with SVT. However, to date there have been no conclusive studies identifying causation between hypercoagulability and SVT. As previously mentioned, migration thrombophlebitis warrants evaluation for visceral neoplasm. Patients older than 40 years with their first episode of thrombophlebitis should also be evaluated for underlying neoplasm. Superficial thrombophlebitis of the superficial breast veins is referred to as Mondor disease. Case series from 1992 noted a 12 and 7 risk of associated breast cancer, but it was a limited study, so it argued that the incidence could have been overrepresented. Therefore, mammography could be considered in patients with this presentation. To help establish the pretest probability for the presence of DVT in patients with SVT, the internal carotid artery occlusion (ICARO) study group has outlined the following 5 variables: active malignancy 1.5, lymphedema 1.5, age of 50 years or more 1 point, a rope-like sign -1 point, and unprovoked SVT. This study suggested this scoring system to help when assessing such patients for coexisting DVT. Low probability, less than 0 points, 1.1% likelihood. Intermediate probability, score 0 to 1, 12%. High probability, scored 1.5 or more points, 32.3% likelihood. However, a more recent study using this scoring system does not support its validity. Despite the number of studies performed, there is still debate on the appropriate treatment for superficial thrombophlebitis. Multiple strategies have been proposed to control symptoms and decrease the extension of thrombosis and risk for pulmonary embolism in low-risk superficial thrombophlebitis. Low-risk thrombosis are those not associated with the presence of or predisposition to other thromboembolic disease. In these cases, the consensus is that non-steroidal anti-inflammatory agents, HATE, and anticoagulations are all responsible. Those who are at higher risk include patients with an SVT in the lower extremities that is at least 5 cm in length, SVT proximal to the knee, especially within 10 cm of the femoral junction, the presence of severe symptoms, greater saphenous vein involvement, previous SVT venous thromboembolic disease, active malignancy, or recent surgery. Based on the Cochrane review published in 2018, these patients should receive fondaparinux 2.5 mg per day subcutaneously for 45 days. This Cochrane review also evaluated topical and surgical treatments, but noted that the data is too limited regarding these treatments and their effects on venous thromboembolic disease, so further studies are recommended at this time. Rivaroxaban 10 mg daily for 45 days was found to be non-inferior to fondaparinux in preventing venous thromboembolic complication with a comparable safety profile in the SURPRISE trial. However, the Cochrane review did recommend further research on its use and the other direct oral factor X or thrombin inhibitors. Additionally, it recommended further study on the use of non-steroidal anti-inflammatory agents and low molecular weight heparins. In those patients who develop superficial thrombophlebitis from an infusion, multiple agents have been evaluated for treatment. Per the 2015 Cochrane review of this topic, there is no consensus recommendation on the safety, dose required, or therapy duration for topical treatments, non-steroidal anti-inflammatory agents, or systemic anticoagulation. Practice in the UK suggests using compression stockings with or without additional therapies, but there is no current recommendation for or against there is in the United States of America. Antibiotics are useful only with clear infection. For Trousseau syndrome, the main priority is to eliminate the underlying malignancy. However, as this is commonly a challenge, heparin is the recommended treatment given that multiple pathways contribute to the development of the thrombus. Low molecular weight heparins have been used, but some have been less effective than heparin. Therefore, further studies are recommended. Fondaparinux has also been evaluated but found to be less efficacious than heparin, and the utility of this agent also requires further study. A case report on the topic recommended the initial treatment with heparin followed by oral anticoagulants but did not specify a particular agent or dosing schedule. Mandor disease, discussed separately, is usually self-limited and benign and will resolve in 4 to 8 weeks. However, if it is due to vasculitis, malignancy, or a hypercoagulable state, treatment is aimed at the underlying cause. It is essential to keep superficial thrombophlebitis on the differential when evaluating a patient. Other considerations include cellulitis, other venous thromboembolic disease, hematoma, lymphangitis, lymphedema, vasculitis, tendonitis, or sports-related injuries and venous insufficiency. The prognosis for superficial thrombophlebitis is related to the underlying cause. In low-risk SVT, it is generally favorable, but there is a definitive risk for recurrent disease. In those with high-risk SVT, the overall prognosis is also positive with appropriate treatment. For those with SVT due to underlying malignancy, the prognosis is related to the causative process. DVT and PE are significant complications of superficial thrombophlebitis. Multiple studies have found concomitant DVT with SVT in 6 to 36% of patients. These same studies clinically suspected concomitant PE in 2 to 30%, and regular performance of lung scans revealed the rate of asymptomatic PE approached. Other retrospective studies from both primary and secondary tertiary centers reported concomitant DVT or symptomatic PE on the initial presentation to be 25 to 30%. About 5 to 7% of these patients had symptomatic pulmonary embolism. However, the incidence of coexisting pulmonary embolism increased to 17 with the use of a more rigorous screening process of asymptomatic patients. Patients with thrombus up to 3 cm from the saphenofemoral junction should be treated for DVT, given that 14 to 70% progress to DVT. Thank you very much for your attention and have a nice day. Bye bye.